Hello everyone. Today we are going to discuss the basics of anemia. So let's dive into it. So what actually is anemia? Anemia is defined as a reduction in total red cell mass resulting in a decreased oxygen carrying capacity of the blood. And obviously, if we don't have enough red blood cells, we can't carry oxygen effectively. Simple, right? But here is the thing. We don't routinely measure the total red cell mass directly. So, clinically, we look at three important parameters. First is hemoglobin. Hemoglobin is actually oxygen carrying protein inside our red blood cells. In men, the normal hemoglobin is approximately 13.2 to 16.7 grams per deciliter. And in women, it's around 11.9 to 15 grams per deciliter. So, if this value is reduced, we start thinking about anemia. Second is hematocrit. Hematocrit is the proportion of the blood volume occupied by the red blood cells. Or, in very simple words, what percentage of your blood is actually RBC? That is hematocrit. Okay? In men, it's around 38 to 48%, and in women, 35 to 44%. And finally, we have RBC count. This is simply the number of red blood cells per microliter of the blood. It's around 4.2 to 5.6 million per microliter in men and 3.8 to 5 million in women. So these are the three parameters we commonly look at when assessing anemia. Now, here is an interesting little trap, and I really want you to understand this one. Hemoglobin is a concentration, so if plasma volume changes, the hemoglobin concentration can change too, even if the actual red cell mass hasn't changed proportionally. This is very interesting. Let me give you an example. What happens in pregnancy? During pregnancy, plasma volume increases, so now we have more plasma around the same red cells. The blood becomes relatively diluted, and the hemoglobin concentration falls. So the woman may have a lower hemoglobin concentration without having the same degree of the reduction in the actual red cell mass. That's why the anemia threshold in pregnancy is lower. It is around 11 gram per deciliter, while in a non-pregnant woman it is 12 gram per deciliter. Now let's take the opposite situation. In dehydration, plasma volume decreases, so the blood becomes more concentrated and the hemoglobin may appear relatively higher. So dehydration can actually mask an underlying anemia. Okay, so what actually causes anemia? I have a very simple way of looking at this. Imagine a bathtub. The first set represents the RBC production and the whole represents the RBC loss or destruction. So there are basically three major mechanisms. The number one is loss. We are simply losing blood. For example, it occurs in hemorrhage. And number two is lysis, or we can say hemolysis. The RBCs are being destroyed prematurely, and this can happen because of intrinsic or extrinsic causes. Intrinsic means the problem is inside the RBC itself. For example, it can be a membrane defect or enzyme defect. Extrinsic means the problem comes from the outside the RBC. For example, mechanical trauma for an abnormal heart valve. Number three is decreased production, or as I like to call it, lazy marrow. The bone marrow is simply not producing enough RBCs. So our basic framework is three mechanisms: loss, lysis, and lazy marrow. Three L's. And if any of these three happens, you get anemia. But how do we know which one is happening? This is where the reticulocyte count becomes extremely useful. But before that, reticulocytes are immature red blood cells that have recently been released from the bone marrow. So think of the bone marrow as a factory. If RBCs are being lost or destroyed in the periphery, like due to blood loss or hemolytic anemia, the factory is still working. It says, okay, we are losing RBCs, let's make more. So the reticulocyte count increases. Therefore, if the reticulocyte count is high, the marrow is responding, you will think of blood loss or hemolysis. Okay? But if the reticulocyte count is low, the marrow isn't responding adequately. So whenever there are low reticulocytes, you will think of decreased production. Okay? And the normal reticulocyte count is approximately 0.1 to 1.5%. But here is an important exception. What happens in thalassemia? In thalassemia, there is decreased production and increased destruction. What? Okay, so there is basically decreased RBC production, and but at the same time, abnormal RBC precursors are also destroyed inside the bone marrow. This is called ineffective erythropoiesis, and we will study this properly when we reach thalassemia. Now, if anemia has developed, what's the body going to do about it? First, we will get hypoxia. There will be decreased oxygen supply to the tissues. The kidneys will sense the reduced oxygen availability and they will release a hormone called erythropoietin. Erythropoietin will act on the bone marrow and stimulates the RBC production. And in severe anemia, erythroid activity can increase dramatically up to 5 to 8 times the baseline. Okay, so more reticulocytes are released into circulation and ultimately oxygen delivery improves. That is the first major compensation. But what if the bone marrow is not sufficient? The body has some backup plans. First is extramedullary hematopoiesis. During fetal life, organs like the liver, spleen, and also the lymph nodes are important sites of blood formation. So in severe chronic anemia, they can basically say, okay, looks like we are doing this again. And they can reactivate the hematopoiesis. That's called extramedullary hematopoiesis. Secondly, our cardiovascular system also compensates. Heart rate increases, cardiac output increases, respiratory activity can also increase. And then we have one particularly important adaptation, which is 2,3-DPG. Its level increases inside the RBCs, and this causes a right shift of the oxygen hemoglobin dissociation curve. What does that actually mean? It means hemoglobin becomes more willing to release oxygen to the tissues. Now, here is another very important point: the rate at which anemia develops matters. A patient with slowly developing chronic anemia can sometimes tolerate a surprisingly low hemoglobin, up to 7 gram per deciliter. Why? Because the body has had time to compensate. But what if the same degree of anemia develops suddenly? For example, because of acute blood loss, there is not enough time for these compensatory mechanisms to fully activate. The patient can rapidly develop cardiovascular collapse and hypovolemic shock. So remember, slow developing anemia is better tolerated and acute anemia is much more dangerous. And patients with underlying cardiac or pulmonary disease tolerate anemia even less well. Now let's move to the morphological classification of anemia. Before we classify them, we need to understand a few RBC indices. There are four important ones. The first one is MCV, which is mean corpuscular volume. It tells us the average size of an RBC. Its normal value is 80 to 100 femtoliters, and MCV helps us classify anemia as microcytic, normocytic, or macrocytic. Okay. Secondly, we have MCH, which is mean corpuscular hemoglobin. This is the average amount or weight of hemoglobin in one RBC. Okay, one RBC. So its normal value is 27 to 33 picograms. And then we have MCHC, mean corpuscular hemoglobin concentration. This tells us the concentration of the hemoglobin within a packed volume of the RBCs. Okay, so MCH is the average amount or weight of the hemoglobin in one RBC. And MCHC is the concentration of the hemoglobin within a packed volume of RBCs. Okay, and it helps us determine whether the cells are relatively hypochromic, normochromic, or hyperchromic. Then we have RDW, red cell distribution width. This tells us about the variation in the RBC size. If RDW is increased, the RBC have more variation in size, and that is called anisocytosis. And normally it is less than 15%. Okay, now let's classify them. If MCV is less than 80 femtoliters, we call it microcytic anemia, and you can easily remember the major causes with the mnemonic tails: thalassemia, anemia of chronic disease, and actually the late phase. Okay, and then there is iron deficiency, lead poisoning, and sideroblastic anemia. If MCV is 80 to 100 femtoliters, it's normocytic. This includes acute blood loss, hemolytic anemias, early anemia of chronic disease. Okay, so the early stage, aplastic anemia, and renal failure because of decreased EPO. Now look at this: blood loss, hemolysis, decreased production. All these mechanisms we have studied in in our mechanisms. All these three basic mechanisms can produce normocytic anemia. That is a very useful way to remember it. You just have to remember the anemia of chronic disease and its early phase actually. But remember one important distinction: acute blood loss is represents the image of normocytic anemia, whereas the chronic blood loss can eventually become microcytic because of iron deficiency. Finally, if MCV is greater than 100 femtoliters, we call it macrocytic anemia. The classic megaloblastic causes are vitamin B12 deficiency and folate deficiency. But here is the important thing: not every macrocytic anemia is megaloblastic. The non-megaloblastic causes include liver disease, alcoholism, and reticulocytosis, and these are very much important. Okay. Now, how does a patient with anemia actually present? The classic picture is paler, especially in places like the conjunctiva and the nail beds. Then, because oxygen delivery to tissues is reduced, patients can develop fatigue, lethargy, weakness, loss of stamina, headache, and lightheadedness or faintness. And because the cardiovascular system is compensating, we can get tachycardia, palpitations, and dyspnea on exertion. That's pretty straightforward. But if the anemia is specifically due to hemolysis, we get some additional findings. One important feature is jaundice. Normally, RBCs are destroyed gradually. The liver has enough capacity to process the bilirubin that is produced. But in hemolytic anemia, RBC destruction is happening much faster. The amount of bilirubin being produced can exceed the liver's ability to conjugate and excrete it. So, unconjugated bilirubin increases that will lead to jaundice. And chronic hemolysis can also lead to pigment gallstones. So, remember, whenever there is anemia and jaundice, you can think of hemolysis. When we have ineffective erythropoiesis, it's exactly what the name suggests. The bone marrow is trying to produce RBCs, but the process is ineffective. The abnormal precursors are destroyed before they mature properly. This can happen in conditions like thalassemia and megaloblastic anemia. And here are two important consequences I want you to remember. First is iron overload. Normally, hepcidin acts like a brake on intestinal iron absorption, but in ineffective erythropoiesis, hepcidin is suppressed. So, intestinal iron absorption increases. And over time, it can lead to secondary hemochromatosis. And that iron can deposit in organs like heart and endocrine organs, and it will cause the organ damage. Secondly, we have skeletal changes. Because the bone marrow is working so hard, it becomes massively hyperplastic, and when marrow expands inside the skull, we can get facial bony prominence, or we can get the classic crew cut appearance on the skull x-ray. I'll show you what that looks like. This is crew cut appearance. Finally, let's have a very quick look at the laboratory workup. We are not going into the details now. We will study these properly with each disease. In iron deficiency anemia, you will get decreased ferritin. Ferritin is actually stored form of iron. Okay, and there will be decreased serum iron, and your total iron binding capacity will be increased. You can remember it as your body's hunger for iron. So if you are iron deficient, obviously the hunger will increase. And transferrin is actually the protein that transports the iron in your blood. And if there is no iron and there is no iron to bind to transferrin, transferrin saturation is decreased. In hemolysis, we get increased unconjugated bilirubin, increased lactate dehydrogenase, which gets released due to the breakdown of the RBCs, and there is decreased heptoglobin. Heptoglobin is a protein that binds the free hemoglobin, in the blood. Why does heptoglobin decrease? Because it binds the free hemoglobin released during the intravascular hemolysis. So heptoglobin actually gets consumed. Okay. In megaloblastic anemia, there is low vitamin B12 or folate, and hypersegmented neutrophils is the key finding. For suspected hemoglobinopathies, we can perform hemoglobin electrophoresis. For example, in sickle cell disease, we can detect abnormal hemoglobin such as hemoglobin S. And in beta thalassemia minor, HbA2 may be increased. For immune hemolysis, there is a test called Coombs test. The direct Coombs test detects antibodies or complement attached to the RBC surface, and the indirect Coombs test detects antibodies present freely in the serum. So Coombs test is positive if there are antibodies either on RBC surface or in the blood serum. And if there are no antibodies against RBCs, Coombs test is negative. And finally, if we suspect a bone marrow disorder, especially when anemia occurs along with abnormalities in the other cell lines, like if there is decreased WBCs or platelets, or we can say pancytopenia, we may need a bone marrow examination. So we do bone biopsy. That's enough for now. We will study each investigation properly later. So what did we discuss today? We learned how we define anemia. We looked at the dilution trap. What happens when plasma volume increases or decreases? Then we discussed the three major mechanisms: loss, lysis, and decreased production, and how the reticulocyte count helps us differentiate them. We saw how the body compensates through erythropoietin, bone marrow, cardiovascular and respiratory mechanisms, extramedullary hematopoiesis, and 2,3-DPH. Then we classified anemia into microcytic, normocytic, and macrocytic, and learned the important RBC indices. Finally, we looked at the clinical features and basic laboratory workup. That's the basic framework. In the upcoming lectures, we will take each type of anemia and study it properly. See you in the next one.